Welcome everyone to our updates in transplantation. This is a quarterly webinar session and today's our spring session. We have a number of transplant experts and infectious disease experts speaking to you today. And with that, I hand the mic over to Dr. Cotton, our clinical director in transplant infectious diseases.
Great. Thanks, Stacy. It's a pleasure to be here again, this time in general with a much happier news. And I'm very pleased to be here with several of my colleagues, Dr. Emily Bethea, who's the medical director of liver transplantation, Nahal Elias, who's the surgical director of kidney transplantation and quality improvement, and Brian Keller, the medical director of lung transplantation. Greg Lewis from the medical director of heart transplantation will be joining us probably closer to 5:30. So today we will discuss some updates from infectious disease, and then we will also be discussing transplant innovations and some tips for summer. So just in summary, in the past, well, not quite last week, but sort of the first half of May, here are the number of confirmed cases by age for COVID-19 in the state of Massachusetts. You can see that overall these numbers are really low. And I think what's impressive to me is I actually kept the numbers from the last time we met. And you can see, so late January to early February, and you can see that those numbers, there's actually a different scale on the left-hand side. Those numbers were much, much higher in January and February, and overall our numbers are much, much lower now. So good news on the COVID-19 front, locally as well as nationally. Numbers for hospitalizations and deaths all continue to plummet, which is just great news. Nationally, only 17% of the population has had one of the booster doses from the bivalent vaccine that was introduced last September. So that's a little just disappointing. If we look at Massachusetts wastewater tracking, so I think many of you are familiar with this, but basically we look at the sewage from the North Shore and the South Shore of Massachusetts, and this has been highly predictive of times when we've had an increase in disease activity. For example, you can see here, January 1st of 2022, when the numbers were super high, that's when we had the Omicron it was around Thanksgiving of 2021 into early 2022. And then overall, our numbers have been relatively low. We did have an uptick around the holidays. You can see this January 21st of this year, these numbers that trickled up. And then overall, our numbers just continue to plummet. So that is great news. This is the North Shore from Massachusetts. The South Shore looks similar. And I would also say that nationally, when we look at wastewater data, those numbers continue to plummet throughout the country. So good news. So there has been a new vaccine permission that I just wanted to make sure everybody was aware of. And in mid-April, the FDA made some changes and the CDC made a recommendation or an allowance that people over the age of 12 who are moderately or severely immunocompromised, so that definitely includes organ transplant patients, have the option to receive an additional dose of either mRNA vaccine at least 2 months after their last dose. And so this isn't an official recommendation to get a second dose. This just is an allowance. And I was just reading data that just came out today where it really looks like people who've had a vaccine within the past 6 months have lower rates of infection, hospitalization, severe disease. And so I do think it is definitely worthwhile talking to your transplant team and or if you want to just going ahead and getting another bivalent booster. We are recommending that people get this, as you can see, at least 2 months after their last dose, but that they actually get it fairly soon because probably this fall we'll have an updated bivalent booster. And we want to make sure that if you get a vaccine roughly every 6 months or so, that you'll be due at the right time for the new vaccine. Happy to have more questions about that during the question section. We'll now go into the Q&A, and these are all questions that you submitted, so thanks very much for your great questions. And what are my recommendations like for shingles and COVID-19? So for COVID-19, everybody who's had an organ transplant more than 3 months ago should have a bivalent COVID-19 booster, which is any vaccine given since last September. And so if you haven't had one since last September, you should definitely go get one because you are not well protected. And if you had one last fall, you should probably get another one now and then plan to get another one this fall. And then for things like shingles, so the shingles vaccine that's been available for the past few years in the United States is a dead vaccine. It was never live, actually. It's a what we call recombinant protein. We do recommend that shingles vaccine be given preferably before transplant, but if you've had a transplant and you're more than a year out, we are recommending the shingles vaccine for all transplant recipients. And that should be covered by insurance now. And in fact, anyone on Medicare should be getting it for free from the Inflation Reduction Act. So that's kind of good news because it was previously a little expensive, but it should be available to everybody. Insurance coverage can be variable, but should be free for Medicare patients. And just, in general, I would recommend that everybody just stay up to date on their vaccines. You can talk to your primary care, you can talk to your transplant team, you can look at the CDC guidelines, but everybody should stay up to date on any vaccine preventable illness. I say it's like wearing a seatbelt in a car. It's just a good idea and keeps you out of trouble. So here's another question. Is it true that I should stop taking my mycophenolate for 2 weeks post-vaccine to improve vaccine efficacy? And the answer here is definitely no. You should not stop taking it. You should never stop taking your immune suppression unless you're directed by the transplant team. And I will say, we initially wondered if this was the best way to go. So maybe we should have people stop some of their immune suppression before a vaccine and after a vaccine, and maybe overall that will result in better vaccine effectiveness and better outcomes. And, I will say that my understanding of the literature, and I'm happy to hear from my colleagues, but my interpretation of the science that's been done is that this actually doesn't help as much as we thought it would. And we thought that maybe stopping before the vaccine and after the vaccine for weeks or a month or so would be really helpful. And it's not been that helpful. So definitely don't do this on your own. And I don't actually even recommend that people do this in general. What changes in critical lab values, such as creatinine, have been observed in patients who have received the COVID-19 vaccine booster? And I have not seen any significant changes in critical lab values. Overall vaccine safety has been really very, very good, very robust safety, and we've not seen any critical lab value changes of significance. On the other hand, people who get severe COVID-19 infection have had a lot of critical lab value abnormalities and can be quite sick. Have you noticed any increases in myocardial or heart issues associated with the vaccine? We have not seen that in our transplant patients. So that is, whoop, can everybody be on mute, please? So we have not seen any of these myocarditis issues with the vaccine. And in general, this risk is very low, especially now that we're spacing the vaccine out. So people are only getting vaccine every 6 months or so, but not closely together. We did notice that not in transplant patients, but in generally younger, healthy men, that we saw more of this when the vaccine was given more closely. Is it true that the COVID-19 vaccine can influence or change my HLA results? And in general, the answer here is no. And we aren't worried that the COVID vaccine, we are definitely not worried that it can cause rejection. So we definitely strongly recommend you get the vaccine, especially where COVID-19 infection could cause rejection. How much protection can immunosuppressed patient expect from the second bivalent booster? So that's the data that just came out today from the CDC, and it does look like you definitely get a boost from the booster. I think my second grade teacher would say that's a bad sentence, but you definitely get an immunologic boost from the second booster, and it is recommended that all transplant patients stay up to date on the vaccines, and I would generally recommend that people get another booster. It looks like basically immunity wanes over time, your protection wanes over time, so you basically need to keep getting vaccines periodically in order to stay boosted and protected against infection. Is it safe to go out in large groups to dine out, public transportation? You know, it's safer than it was. I would still be somewhat cautious, like large groups, you know, if going to a concert or going to an area where people are really crowded, I think there's nothing wrong with wearing a mask. Lots of people are still wearing masks in those situations. Dining out, I think, is probably safer than it was. Luckily, it's summertime, so maybe you want to eat outdoors anyway. But if you're going to a restaurant, one thing I do is I'll wear a mask when I'm maybe walking through the restaurant where it's crowded and I'm breathing other people's air. I say the whole thing is just don't breathe other people's air. And then once I'm sitting down at a table and about to start to eat, then I'll take off my mask. But I don't necessarily need to wear a mask as I'm walking past hundreds of people to be seated. And then public transportation, I think for many transplant patients, you may feel more comfortable wearing a mask. However, if you do get COVID, we do have good treatments, and I'll talk more about that. There was a question, what % of the population has had COVID-19? And basically it looks like we're not quite at 100%, but it looks like as of last August, so not quite a year ago, but 96% of the US population had had COVID. So it's even higher than 96% at this point. So super high. I'm sure you've heard many people are getting their second or third infection at this point. So super high. Here's the map of the United States. I just want to say that Florida, it's not that they're safe down there in Florida, they just didn't submit the data. Anyway, so you can see that there's really widespread high rates of COVID across the entire country. Do we require the COVID-19 vaccine pre-transplant? And if so, why? And yes, Mass General Brigham, which is the large healthcare network, does require COVID-19 vaccine before transplant. And that's basically because it is a life-saving vaccine, and not having the vaccine could result in higher rates of significant illness, life-threatening illness, hospitalization, and death. And we really want to do everything possible, as you know, to protect our transplant patients. And so we recommend all routine vaccines be given prior to transplant whenever possible. And that's why. There's good medical science behind this, and we practice good medical science. I was recently transplanted. Should I get the latest bivalent COVID-19 booster or wait until the fall? So in general, we recommend that boosters be given starting at least 3 months after transplant. If you just had a transplant within the past few weeks, the vaccine is going to be less effective. But if it's been at least 3 months, I would get a booster now, and then I would get a booster in the fall. Okay, and given studies pointing to its effectiveness in reducing transmission of airborne disease, why did Mass General eliminate masking? So this is a somewhat complex situation, but as I showed you, rates of disease are really low these days. And we also have very low, virtually zero rates of influenza, RSV, and some of the other respiratory viruses. So we are taking this opportunity to stop mandatory masking, although certainly anybody who wants to wear a mask at any time is definitely encouraged to do so. And I will say that I often am wearing a mask in the hospital or when I'm seeing patients in clinic, et cetera. And I think many of us are respectfully, as the question reads, reducing transmission of airborne disease and thinking about that. So we just made it no longer mandatory for everyone. So how do I protect myself for my appointments, or if I'm admitted? Wear a mask. There you go. You can wear a mask at any time. Anyone is welcome to wear a mask at any point. If I'm admitted after transplant, what should I expect after discharge? I think I'm not quite sure what this question is about, but basically if it's about COVID-19, I would think about masking whenever you're in crowded places, et cetera. And if this is just a general question about transplant, we do a lot, the nurses on the transplant floor do a tremendous amount of education. So perhaps that's what the question relates to. There's a whole transplant handbook that's available online. that you could have access to if you wanted, if you don't have access now. Is remdesivir still the best treatment option for COVID-19? So we think that both remdesivir and Paxlovid are very good treatments for COVID-19. Remdesivir is still available, still the same mechanisms. My understanding is that the insurance companies, because the emergency status of the COVID-19 pandemic is no longer in active, that remdesivir, there may be copays with the remdesivir that there were not previously, and same for Paxlovid. But these are very good treatments, and we don't really have updates on treatment. So it's either remdesivir or Paxlovid, and we fortunately have not had to give much Paxlovid to our transplant patients because it's very, very hard to control the drug interaction. And so we have really shied away from using Paxlovid whenever possible, and we preferred to go with either remdesivir or molnupiravir, which does not have the drug interactions. But for safety, we've kind of stayed away from Paxlovid. We did develop a protocol so that we could potentially safely use Paxlovid, but the drug interactions are profound, and we've really tried to shy away from that for safety. I'm post-transplant and traveling abroad. What precautions should I take? So I always say, think about where you're going, think about disease rates, think about what it would look like if you got sick. Would you have access to remdesivir? Would you have access to molnupiravir? What would they have hospitalization capacity where you're going? What would that look like? And certainly whenever you're traveling abroad these days, always be ready for travel delays. Make sure you take enough medications with you. Make sure you have a plan in case you get sick in that country. And there's a great CDC website called CDC Destinations, and you can put into like a Google search, but CDC Destination and the country of choice. And there are a lot of information about different countries that you could read over if you're planning travel. Just to highlight, there are some yellow fever zones. And because if you haven't previously had a yellow fever vaccine, we do recommend that transplant patients shy away from these areas in either yellow or turquoise or red whenever possible, because you could get exposed to yellow fever, and we can't safely give you this live viral vaccine. Otherwise, we're happy to help you travel to many places throughout the world. And I will turn this over. We are going to talk about transplant innovations. And I'm not actually quite sure which of my colleagues is going to be addressing these.
I will start, Camille. Thanks a lot for an excellent summary. And thank you all again for attending, and we appreciate your questions. And this is where I'm going to take over for a couple of questions that were coming in about some of the innovations that we're doing. Is it true that a post-transplant patient no longer needs to take immunosuppression? So the first and foremost, the answer is not without the direction of your transplant physician. Whoever's taking care of you in the clinic should help you with that. In general, patients need immunosuppression for the rest of their life, or at least the life of the organ they got. And so for kidneys, occasionally we stop immunosuppression if the kidney fails and they go back on dialysis. But through special protocols, there are what we call tolerance induction, where we induce tolerance, or where patients can tolerate the organ that they're being transplanted. And that was one of the other questions: how does clinical tolerance for transplantation work? And we're one of the pioneer centers. And since before I joined here, actually going back 20 some years, our center has been working on this. Dr. Kawai is leading the work with this protocol specifically for a combined kidney bone marrow transplantation. That's what CKBMT stands for. So what we're doing is essentially through chemotherapy and special immunosuppression, which is induced prior to transplantation for a week. And that's why it requires a living donor transplant in this protocol. We've had patients undergo this protocol, and this has been revised over the years that we've been doing this, and we continue to do it. And we currently have a protocol where, as you see, the immunosuppression post-transplant is about 20 days of steroids and 1 year of tacrolimus, and then at some point this is tapered off and removed. But again, it's under strict guidelines and direction by the transplant provider. So because we require 7 days of induction therapy or conditioning, we call it, prior to transplantation, this has to happen with a planned scheduled transplant with a living donor kidney, which is what we are currently doing selectively. In the future, we're also talking about what we call delayed kidney tolerance, where for a deceased donor patient recipients, the kidney transplant happens first. We are actually saving bone marrow from the donor, the deceased donor. I isolate the stem cells and freeze them to be able to do the bone marrow transplant later on after a conditioning regimen, and then move the patient to becoming off immunosuppression. So in between the kidney transplant and the bone marrow transplant, the patient is still on immunosuppression, and then through the conditioning regimen. This is also, there's an opportunity to do this with a living donor transplant for those who received the transplant already, and their living donor is available to get these stem cells, these special cells that we either get from the bone marrow or we get from leukapheresis. So they're recovered from the blood and the peripheral blood, and that's how the donor could donate. So again, there's a lot of these protocols that are ongoing. There are a few other centers across the country that are doing similar work, but we really have led this work across the country and internationally as well. There's a question about how long before we can grow kidneys from our own cells. I doubt that we'll be able to do this in my lifetime, or at least my my lifetime as a transplant surgeon, I should say as well. But it is there's some centers that are working on things of this nature, and some of the other innovation as well. I don't know if Greg, I don't think Greg joined us yet, but that was one of the other innovation that has done with the heart transplant first, is that they performed a heart transplant without using blood products at all on a Jehovah's Witness. And this was publicized in our website. And an additional innovation that the heart transplant team has performed is they got a heart flown from Alaska to Boston, breaking a transplant record. And there's a news story on this as well on Channel 7. It was amazing work by the team, and through some of the innovation that they're doing, and we continue to do it. What are the other innovation that we're seeing in the future? Are you probably hearing some of the other centers doing some work with the animal organs, and we are doing some of that. This is what's called xenotransplantation. Again, it's not ready for prime time, but there's a lot of innovative work that's going on that. A lot of work on different immunosuppression regimens and different ways that are safer immunosuppression and less harmful immunosuppression is something we're always working on. I don't know, Brian or Emily, you want to have a couple comments on this?
Sure, I can comment. So on the lung transplant side of things, we've been utilizing partnership with a company that utilizes the technology called ex vivo lung perfusion. And this is a machine that allows us to have a little more time to evaluate the quality of donor lungs and even optimize them in some cases. It also allows us to transport lungs from further away, evaluate their quality to make sure that they're still in good shape in order to be transplanted. And we've now done a couple of transplants using this technology. And so we're excited about the future and the ability to use this technology to, enhance our ability to get transplanted organs to our patients faster.
Thanks, Naha and Brian. I don't have a lot to add. I think similar parallels in liver. I do think there's efforts being made both in the space of kind of machine perfusion and the ability to kind of keep the liver perfused if we're anticipating a longer, more complicated OR case or certain types of organs that people have talked about before. Some of the other things we've been working on in liver that kind of parallel what was mentioned by Dr. Lewis and the heart team are thinking about the types of transplants that can be offered to patients who maybe have the liver as a bystander. It is another systemic process. And so one thing here we've been working with our hematology group closely on is the sickle disease population and ways that we can think about some of our staged liver followed potentially by stem cell and other transplants, or using gene therapies and things in the stem cell population and trying to increase our availability or offering of things that weren't being done previously. But I think there's a lot to talk about in this area, and I think there's a lot of good questions everyone has too. So we'll try and continue on with that.
Great, thank you. How do I know where I am on the transplant process, my place on the wait list? So the wait list is different for different organs. There are the best answer to this based on which organ you're on the wait list for is to talk to your coordinator. I'll speak for kidney. Kidney wait list is primarily by how long you've been waiting, and patients who've been waiting, we have a schema talks about how the process works. And when the patients are on the wait list, we are communicating with them on a regular basis, waitlist status, active or inactive. So inactive patients do not receive organ offers, but they still accrue time on the waiting list. And usually we let them know while they're inactive to work on it till we can get them to activated. And time accrued is based on the date of initiating dialysis or getting on the list, whichever is earlier. The time on the waiting list for kidney right now is roughly about 6-7 years for O blood type. Blood type A is 5, blood type B about 7, blood type AB is about 3 to 4 years. For other organs, the waiting list is more by how sick the person is, and that applies to heart, lung, and liver. Each has their own scoring, and occasionally patients go on the list and they're sick enough to be ahead of everybody else. And some other scenarios where you have a patient who's waiting for 10 years because they're not sick enough, and they're not waiting because they're well enough that they can wait. And again, that your coordinator would be the best person to communicate with to answer that question. Some summertime tips for transplant patients. So first of all, stay well hydrated. We know the kidneys love water. We always talk about that. It's always important to keep your kidneys well hydrated, and that applies for kidney patients, kidney recipients, but also to other organ recipients, because unfortunately some of the immunosuppression medication does affect the kidney, and patients who had a heart, lung, or a liver transplant previously may have some kidney dysfunction, and keeping your kidney well hydrated is important, especially in hot summer months. Adequate hydration will maintain the organ function and supports the overall health. Plenty of fluids during the day, and make sure your urine is clear. Avoid sugary or caffeinated drinks or alcoholic drinks. These are all cause increase in how much urine you produce. You actually, as I tell the patient, you're actually hydrating yourself, but you're wasting more hydration than you're getting hydration out of a sugary drink or a caffeinated or alcoholic drink. So it's better to stick with less sugar, less caffeine, and less alcohol or no alcohol. Skin protection is very important. Skin cancer, non-melanoma skin cancer is still the most common cancer we see across the board, and definitely more so in immunosuppressed patient. Immunosuppression does increase slightly the risk for cancer, and the skin is very photosensitive, especially light skin patients. So always apply sunscreen SPF 50 or higher to prevent sunburn, reduce this risk of skin cancer. Less skin exposure with protective clothing, hats, long sleeve shirts, sunglasses is very useful, and make sure you connect with your team when you have any questions about any of these. Be mindful of your medication. Heat and sunlight could affect the potency and stability of medications. Store your medication in a cool, dry place to avoid exposing them to direct sun. Ensure proper storage and carry them in your hand luggage as you're flying. And always check with us. We always have a pharmacist in the clinic who can help you with any specific questions about these, and your coordinator can get you connected to a pharmacist, one of our transplant pharmacists, or your local pharmacist would have some good advice to know about these important pieces. Manage your outdoor activities wisely. Engaging in outdoor activities is enjoyable, but it's crucial to make sure you manage your time and exposure to extreme heat. Plan your activities during the cooler part of the day. Take breaks in shaded area and make sure you rest as your body tells you to. Preventing exhaustion or overheating is important. And stay vigilant for infections. Summer brings increased risk of infections such as foodborne illnesses and insect-borne diseases. It's always important to maintain good hygiene practices. Wash your hands frequently with soap and water, particularly before eating or handling food. Insect repellents are important. Avoiding tick bites is important. And if you're doing a barbecue, don't use the same board for raw and cooked meats. Make sure you separate those to avoid some of these infections. I am not sure what this question is about. How do exercise and diet help in blank disease?
So essentially, I think it was a kidney disease patient who asked this question. So this is basically to cover all our bases with the other organs as well, inclusivity.
Okay. Well, for kidney disease, important pieces with diet is hydration, as we talked about. Less salt is important, less sugar, especially for diabetics to manage their sugar, and even the non-diabetics, they're at a slightly higher risk for diabetes after transplant. Exercise, as we were talking, just to manage, avoid exhaustion and dehydration, because with exercise, especially in the hot weather, you're gonna be losing fluid by sweating, and that's important to gauge that appropriately. It's probably similar advice for liver and heart and lung patients. I don't know if Brian or Emily have any comments.
I'm happy to comment. I think a lot of times people do ask, what's the best diet for a liver? Overall, a healthy diet is the best diet for the liver, and so similar to what Dr. Elias had said, trying to be thoughtful about things that are healthy overall, fruits and vegetables. If there's medications that like increase some of your electrolytes, maybe you have high potassium for a reason or other things, just trying to abide by sort of restrictions and keeping within the goals. But in general, it's overall healthy diet, and then overall exercise, especially, it doesn't always have to be strenuous, but sort of exercise in and of itself for heart health, overall health, and some of the things that also help in the post-transplant setting where maybe your metabolism or other pieces are slower impacted by medications. It can be helpful to try and keep up with some level of daily exercise and activity.
I'll just add a couple of comments as it relates to lungs. Diet and exercise are very important both before and after lung transplantation. Pulmonary rehabilitation, both before and after lung transplantation, is critical. For patients with end-stage or advanced lung disease, pulmonary rehabilitation has been shown to reduce symptoms and improve quality of life. And it's also a requirement of our patients after transplant to help them recover from their surgery and kind of get back up on their feet and get back to a more normal way of life. Diet's also important. We want patients to, as Dr. Bethea said, maintain a healthy diet. Weight gain, particularly after lung transplantation, can kind of cloud sometimes the monitoring of how the lungs are doing, and particularly if the weight gain is in the more in the abdomen, and that can kind of push up on the diaphragm or the breathing muscles and can reduce your overall lung function, and that can sometimes mimic what rejection looks like. And so when people gain weight, it makes it difficult to know if it's the weight gain or if it's rejection that's causing the decrease in their lung function. And so maintaining a healthy diet and active exercise and a healthy weight is important both before and after lung transplant.
Thank you both. That's excellent. And this completes our questions we have already. Please complete the survey and follow us on social media. Is that for me or for you, Stacy, to say?
For anybody, but there were a couple of questions that came through like right before we started, so I didn't get to capture them in the slide deck. And I think Dr. Cotton is going to answer one of them. One is it really necessary to get another COVID shot? Each one makes me sick for up to 3 days. It takes coordination to plan around it, and it trashes my time to do stuff when I am not working.
Yes, so that's a common question that I get both from friends, family, my community, and patients. So unfortunately, I do still recommend that you get the vaccine because I think it can prevent you from potentially life-threatening illness. And I do appreciate that it's hard to plan. I myself recently got Shingrix, and I planned, I usually get my vaccines on a Friday so that if I get a fever or whatever, I can still go to work and do things. I know that we all have had to make some accommodations, but I would still recommend that you get the vaccine because we do see life-threatening illness in people that are poorly vaccinated. Disease rates are lower, so it's less of a risk, but we are still seeing a brisk amount of disease out there. In fact, I know multiple infectious disease specialists or their family members have unfortunately gotten COVID after the COVID-19 emergency ended, which caused us to chuckle saying, isn't the pandemic over? But we're still seeing a good amount of disease. So I would recommend, even though you don't feel well after the vaccine, you may actually feel a lot worse if you get COVID. So it's one of those times you don't want to say later, like, oh, I wish I'd gotten a vaccine and I wasn't hospitalized for 2 weeks. So there's that. There's another question. When will AstraZeneca's Supernova clinical trial proposal for experimental monoclonal antibodies to prevent COVID infection in immunocompromised patients be approved at MGB? It has already been started at over 50 sites across the country. And I don't know if others on this call are aware. I don't believe it's going to be opened at MGB, not that I'm aware of, but maybe somebody else can correct me. Clinical trial sites are picked for a variety of reasons, and I don't know why we weren't necessarily picked as a site. You could potentially enroll at one of the other sites. So if you are able to see the 50 sites all over the country, if there's one that you could get to, you could certainly enroll there. Just because you're a Mass General transplant patient doesn't, or wherever you had your organ transplant, you could potentially be enrolled at another study site for a clinical trial. I will say clinical trials are clinical trials, so it's not necessarily known to be effective or safe. So hopefully if they do find it to be effective and safe, then we will be able to roll out monoclonal antibodies similar to before, although it'll probably be different. Probably it won't be free the way we were doing before, because with the end of the pandemic earlier this month, many things are now going to have copays or other standard medical costs associated with those. And you know what, while I have the mic, there were a couple of people that asked questions that are challenging. Some of the more challenging questions I get about what can my spouse do? Or can my spouse now go outside without a mask? Can my kids go to school without a mask? So disease rates are lower, but they're not zero. The way most of us got infected was actually from our friends, families, and loved ones, the people closest to us. It wasn't the person who was 50 yards away in the grocery store. It's actually in our homes, people that we're intensely exposed to. So in general, we would still encourage family members to be making good choices. If a family member is going to the Bruce Springsteen concert, they're going to be exposed to a heck of a lot of people, and they may well get COVID. Now, you can do things in the home, like that person could mask for the next 5 days in the home, or people could kind of live separate lives in the home. Certainly not sleep in the same bed, because that's kind of a very intense ground zero that goes on for hours. So good to kind of separate, and do maybe throw some testing in. Or they could wear a mask at the event. I do think that for casual, low-level exposures, people can probably do away with some of the masks if you are comfortable with potentially an increased risk of infection. The child thing is tricky. I saw somebody this week who has a 5-year-old who's in preschool, And, that's a really important conversation to have, because there's 3 years into the pandemic, kids masking are probably not learning as effectively. They're not learning social skills as effectively. And with low disease rates and heavy rates of vaccination, as well as good treatment options available, it may be time to decide for your family that your child will go unmasked in school. Now, some people are going to feel comfortable with this and some people aren't. And this is where we are all at a personal opinion, personal decision-making issues around that child or your children or grandchildren or whatever it might be. In the beginning of the pandemic, when disease rates were sky high, it was a pretty easy decision to make. And I think now we're moving into the phase where people should be thinking about risks, benefits, and all types of things. Now, if disease rates go up again, we will probably start mandatory masking again at Mass General, and the community should maybe mask, but maybe this now, especially summertime, lots of outdoor activities, maybe now's the time to decide that we're not, maybe get another bivalent booster, so protect yourself well, and then maybe think about having a more unmasked summer compared to before. And I would gladly appreciate input from my colleagues on this, as far as what your thoughts are and what you're counseling patients and families.
I would agree, Camille. I think it ends up being in many ways a personal decision. There's been a lot of changes and iterations over the past few years with everything that people have been through. And I think it's very reasonable to also talk to your providers about your specific case. How have you been doing after transplant? What medicine, pre or post-transplant, I should say, what medicines are you on? How immunosuppressed do we feel like you are? What complications have you had? But in general, we're really trying to work with patients to allow them to get back and engaged in social activities if it's within kind of the level of risk that they feel acceptable. If there's things that make them feel more comfortable, testing, like Camille said, doing things outside, all of that's highly encouraged.
So Dr. Lewis has joined us. I don't know if you'd like to say a few words, Dr. Lewis. We did cover some of your transplant innovations for your team, but the mic is yours.
Oh, great. Thank you, Stacey. I apologize for joining late. I had to attend to another meeting, but no, I think that thanks for covering some of the innovations. I'll look out for questions from that are heart transplant specific in the chat.
Right. Do we have any more questions? I think a lot of the questions coming in look to be duplicates. I see one asking for more information about the sensitized kidney population when it comes to waitlist times. Dr. Elias, can you speak to that?
Thank you, Stacey. That's a good point. And sensitized patients are patients who've been exposed to someone else's blood, either through prior transplant, blood transfusion, or women who've had pregnancies, especially more complicated pregnancies and deliveries. And sensitization is one of the ways patients get more points on the waiting list. So some patients who are very highly sensitized, we say, where they're sensitized to a high percentage of the population, end up becoming really high on the waiting list. It's unfortunately not a great way to get more higher on the waiting list, because it's eliminating a number of donors to be suitable for you. So many, so when a patient is, for example, we call them 50% sensitized, essentially by the characteristics of the donors, deceased donors that were identified within the past couple of years, about half of them do not match this patient. So what that means is that patient will have to wait longer to find the match. But to alleviate that, the system allows these patients, sensitized patients, to get more points, to get higher on the list, or sometimes get national priority. So patients who are really, really highly sensitized, more than 99.5% sensitized, that means only 0.5% of all donors are potentially match this person. they get national priority. And if there is a match for them with any donor across the country, that kidney will be allocated to this patient. It's, as I said, it's not a great way to get more points. It's a tougher way to get a transplant, and it becomes more complicated. We help patients who have a potential living donor. If the living donor doesn't match you because you're sensitized, this is where opportunities for what we call the paired exchange, or commonly referred to as swaps. You know, your potential donor will donate to someone else who has a donor who will donate to you. And if we participate with national change, so we're not looking at it only internally, but we're looking at it across the country with through an outside company that helps us facilitate this and coordinate these swaps or paired exchange chains. And that way you'll get a kidney from someone else and somewhere else in the not at MGH. Your donor will donate at MGH and the kidney will go to the patient that it's suitable for, and you'll get a kidney from wherever across the country. And we can facilitate these transplants so your donors donating and your transplant as a recipient don't need to happen on the same day. Your donor couldn't donate ahead of time, and we can coordinate all that based on your preference and your donor's preference.
A question just came in. What is it called? Sorry, I'm not sure. Theodore, what that's referring to.
I think it's
Just let us
referring
know.
to the recording of this conference.
Oh, yes. So we will be posting it. We always record these sessions and post them on our YouTube page. It does take a couple of days. So I typically suggest folks follow us on social media. We will post an update when it is up. But I also do send it out by email to everyone who's registered to this program. So keep an eye out in the next 2 to 5 days.
You know what? I'd actually like to take this moment to thank Stacy, who has led this effort, because when I put these out on Twitter, many people say that they wish their transplant center did this for them. And so, Stacy, thank you for organizing all of these. You've done an amazing job. You're so responsive to what patients are asking for. And you make us really proud to be part of the MGH Transplant Center with the work you're doing and spearheading nationally.
Ditto. Thank you.
Stacey.
And I apologize if this was covered already, but I also would like to thank Stacy. And, you know, we've been very fortunate to have Camille kind of leading the way with a lot of the very COVID-centric topics. But I think going forward, it is an opportunity to branch out into, you know, other areas of transplantation. And I think we would welcome ideas or thoughts that you may have as transplant recipients as to topics that may be of particular interest for these types of seminars, because I think we all have an opportunity to learn from each other in this forum.
Absolutely. And I will put a plug in again. You will get a survey at the end of this program by email, and it'll automatically put you to a different website asking you to complete a survey where you can provide your thoughts, feedback, and suggestions for future webinar events. And again, follow us on social media and let us know your thoughts there as well. So with that said, oh, it looks like we have a couple more questions that are coming through.
Stacey, there's one question on how COVID-19 infection may affect your transplant. Being with the lung transplant program, so COVID infection obviously is a respiratory infection, and so it can have direct effects on the lungs of lung transplant patients. And in addition to the effects of the infection, what we have seen in some cases are patients developing some cases of rejection in the weeks to months after infection. Now, we don't have enough information to know that this is a direct effect of the COVID infection, but just the fact that we've seen it in some cases does raise our suspicion that this virus may be kind of triggering rejection in some of our patients. And so we do want to, continue to encourage people to mask and be cognizant and and use protection as much as possible and trying to reduce the risk of infection. And then we do recommend close monitoring and communication with your transplant team if you do acquire a COVID infection, because they may want to keep a closer eye on you for a little while just to make sure that everything that you recover fully.
Yeah, absolutely. I would add to that the point that Camille brought up about vaccination and the severity of illness. I mean, that's what we've seen. I have a patient that I've done a liver transplant on who had a severe illness from COVID, actually affected his kidneys quite a bit. And he was in the hospital for a long time. And that's where other organs are affected by the COVID infection when a patient is a transplant recipient because of their immunosuppression state and the immunosuppression affecting the kidneys. And that adds to the complexity of the outcomes of these patients getting COVID. And this is where if we get to avoid it, it's great. And that's why we're still requiring the vaccine, as Camille mentioned earlier.
I was going to say out loud, because Camille, I've actually had a number of questions in clinic about the high dose flu, and I saw you kindly answered that one, but just to sort of say to the group, I know a number of patients have asked about and wanted to receive the high dose flu vaccine. We do recommend the annual flu vaccine, but it sounds like right now, in large part, it's only covered by insurance when you're over 65, but it sounds like something, all the things we thank Camille for, it sounds like something they're also working on at the CDC level to try and see in immunosuppressed patients or post-transplant patients if it is something to be recommended down the line. I'll let you comment, Camille, if there's anything else. But
Thank you. Thank you for carrying forward my message in clinic too. All flu shots are good and work on some level much better to get a flu vaccine than not. When possible, I think it's good to get the higher dose, but in general, they're not covered by insurance. And then we're really handicapped if you're under the age of 65. I want everyone to know that I have read the medical information, I have reviewed the literature, and I personally have really pushed hard on the CDC level. I'm not sure if everyone in the audience knows I'm on the CDC vaccine committee. And so that's been one of my babies, is to push forward approval or a recommendation, so that insurance approval for the high dose influenza vaccine for immunocompromised patients. And I will tell you, we're working on it. It's not something that's going to be this year. I'm sort of cautiously optimistic it may come out for next year's influenza season, but I am pushing for that. I push for all things for the immune compromised in order to keep everyone safe and healthy. I will say that I hope that everybody takes the opportunity to have a wonderful summer. It's been a long 3 years, and I think with all the recommendations about how to stay safe and healthy this summer, it's good to take this opportunity to really enjoy yourself, stay hydrated, careful of the sun, careful of ticks and mosquitoes. I always say nobody wants to come see me in clinic if they can avoid it, right, everybody? But do take this time, because in the fall, we might have influenza again, respiratory syncytial virus, those kind of things. We'll probably, I think all the faculty on this call will probably be throwing on some masks more frequently, because we've figured out a lot about how masks work. But take the opportunity to have a wonderful summer.
Thank you, Dr. Cotton. I have one question here asking about support groups, and I did want to make mention that we did host support groups in the past before COVID, but with COVID disrupting a lot, we did put a pause on that, but we will be reinstating those sometime in the future. So please send me your information. I'll be happy to let you guys know whenever that is back up and running. And I can send everyone my email address, or you guys should have my email address. Yeah. And with that, I think we are all set with questions. Anything else that you guys want to say before we part ways?
There's one quick question about, can you get COVID and influenza vaccines at the same time? And the answer seems to be yes, you can. If you feel like separating them just because you want to, you can. I think all the doctors on this call can't separate them because I know you guys won't show up for the other vaccine. I know how doctors work. So for all of the doctors on the call, you guys should get them at the same time. And then if people feel like separating, you can, but we have enough data to show that it looks to be safe to get them together.
All right. Oh. My email address. So I will send everyone my email address right after this program ends. All right. Well, with that, I want to make sure I don't miss anybody else's questions. Right. Well, have a nice evening, everyone. Thank you again for joining us. Follow us on social media and let me know if you have any questions.
Thank you, Stacy, for great work. Thanks, everyone.
Thanks,
Thank you.
Stacy.
Bye.
Bye,
Thanks,
everyone.
everyone.
Bye.